Gallian Baree Syndrome, or GBS, is an acute, immune-mediated polyneuropathy causing rapid-onset muscle weakness and paralysis due to demyelination of peripheral nerves. GBS is defined as an acute autoimmune polyneuropathy affecting peripheral nerves, leading to symmetrical weakness and paralysis with areflexia. The inflammatory demyelination disrupts nerve signal transmission. The most common GBS type in Europe and North America is acute inflammatory demyelinating polyneuropathy, or AIDP. In Asia, axonal forms like AMAN and AMSAN are more prevalent. GBS is primarily autoimmune, but other etiologies include toxic exposures, such as botulism and heavy metals. Metabolic disorders and infections are also implicated. Campylobacter jejuni is the most common infection, preceding about 30% of cases. The pathophysiology involves an immune-mediated attack on the myelin sheath and axons due to molecular mimicry. This triggers complement-mediated myelin destruction, leading to nerve conduction block and paralysis. Clinical features often include a preceding infection, progressive symmetrical weakness starting distally, and loss of deep tendon reflexes, which is a hallmark sign. Additional features include autonomic dysfunction, cranial nerve involvement, and respiratory compromise, which occurs in 20% to 30% of cases. The GBS Disability Score assesses disease severity, monitors progression, and predicts long-term outcomes. A higher score at onset indicates a poorer prognosis. Diagnosis relies on clinical findings, electromyography showing demyelination, and cerebrospinal fluid analysis, often revealing albuminocytologic dissociation. Respiratory function testing is crucial. An FVC less than 20 milliliters per kilogram suggests impending respiratory failure, and a negative inspiratory force less than 30 centimeters H2O predicts the need for mechanical ventilation. Other tests, like FEV1 and peak flow rate, assess respiratory function, and an arterial blood gas is obtained for patients with reduced respiratory function. Management requires treating any patient with suspicious symptoms as GBS due to the risk of respiratory failure. Plasma exchange removes autoantibodies and improves outcomes. Intravenous immunoglobulin, or IVIG, is another key treatment, although it is expensive. Corticosteroids are generally not recommended alone, as they can delay recovery. Supportive care involves close monitoring for respiratory failure and autonomic instability. Pain management and physical therapy are also essential components. Complications include respiratory failure, autonomic dysfunction, and neuropathic pain, which is common in up to 80% of patients. Other complications are DVT and PE due to immobility, pressure ulcers, chronic fatigue, and psychosocial impacts like anxiety and depression. The majority of patients, about 80%, regain full motor function within months to years. However, 20% remain disabled, and mortality is about 5% despite treatment. Predictors of poor outcome include older age, severe initial weakness, the need for mechanical ventilation, and rapid progression of symptoms. For further details, please refer to Davidson's Principles and Practice of Medicine 21st edition. Another useful resource is Rosen's Emergency Medicine, Clinical Concept and Practice, specifically the section on neurology.